Hello guys, today we have a cardiogenic shock question, and we will talk about the parameters you have to know to get this type of questions right in your exam. Let's start with a question. A 67-year-old man is brought to the emergency department due to severe shortness of breath and chest pressure for 2 hours. He has a history of hypertension, hyperlipidemia, and type 2 diabetes mellitus. So that's obviously a patient with a predisposition to an ischemic heart disease. Temperature is 37 degree, blood pressure is 78/50, which is low. Pulse is 124 per minute. Respirations are 28 per minute. Physical examination shows cold extremities, jugular venous distension, and diffuse bilateral crackles. ECG demonstrates ST segment elevation in leads V1 and V4. V1 to V4, okay? So that's obviously a patient with a myocardial infarction, and you can see that from the distended jugular vein and diffuse bilateral crackles and the ST segment elevation in leads V1 to V4. In the question he asks you about the hemodynamic measurements that can be seen in this patient, and he gives you some arrows in the answers. Those arrows most likely represent some parameters. Those parameters are central venous pressure, cardiac output, and PCWP. The PCWP reflects the left atrial pressure, by the way, and the central venous pressure reflects the right atrial pressure, okay? And systemic vascular resistance. In a cardiogenic shock scenario, the heart can't push the blood forward. So the blood accumulates and gives a back pressure, okay? And that can be seen as a high PCWP, which reflects the left atrial pressure, and a high central venous pressure. And the high central venous pressure can be seen in physical examination as a distended jugular vein, okay? And the cardiac output will be low, the systemic vascular resistance will be high as a compensation for the low cardiac output, okay? The low cardiac output makes the body activate the sympathetic nervous system, which causes vasoconstriction and high systemic vascular resistance, okay? The O2 saturation is low. Let's compare those parameters to a scenario of a hypovolemic shock. A hypovolemic shock, most likely due to hemorrhage and dehydration, will have a low CVP and low PCWP, okay? Why? Because simply there is no blood in the circulation, okay? So central venous pressure and PCWP is going to be low with a low cardiac output and high systemic vascular resistance as a compensation for the low cardiac output, okay? Now let's talk about the obstructive shock. The mechanism is impeded cardiopulmonary blood flow. There is something impeding the blood from going forward, okay? And the causes are divided into two divisions. The pulmonary embolism with the tension pneumothorax and the cardiac tamponade alone. And the difference is with the PCWP. Low with the first division because the blood is blocked from going to the left atrium. So the PCWP or left atrial pressure is going to be low with a high CVP. But with the cardiac tamponade, the PCWP high with a high CVP, and both have a low cardiac output with a high systemic vascular resistance. Okay? Regarding the distributive shock, the mechanism is widespread systemic vasodilation. Whether caused by sepsis, anaphylaxis, or sinus injury, the hallmark parameter is low systemic vascular resistance. Okay? And I want you to take note that the O2 saturation is high with sepsis, especially in early sepsis. Okay? And the cardiac output too is going to be high. Okay? So we have to note that the cardiac output is high and the O2 saturation is high with a low systemic vascular resistance. Okay? Let's get back to the question. The first answer has a high cardiac output with a low PCWP, low systemic vascular resistance, and high O2 saturation. That's the wrong answer. Okay, that's the answer for an early septic shock. As I said before, in early septic shock, you have a high O2 saturation with a high cardiac output, and a hallmark for distributive shock, a low systemic vascular resistance. Okay. The second answer has a low cardiac output with a high PCWP, high systemic vascular resistance, and low O2 saturation, and this is the right answer. Okay. Low cardiac output, high PCWB because of the back pressure to the left atrium, and high systemic vascular resistance as a compensation for the low cardiac output and a low O2 saturation. Okay. The third answer have a low cardiac output, low PCWB, high systemic vascular resistance, and low O2 saturation. That's the answer for a hypovolemic shock. Okay. So the right answer is the second answer. The last question. Okay, in order to not waste more time, this is a case showing a patient with a myocardial infarction. Okay, and he is asking you about the best explanation to this patient's hemodynamic state. Okay, the first answer, decreased systemic vascular resistance with increased cardiac output. Okay, that's the answer for an early septic shock. The second answer, increased pulmonary capillary wedge pressure with decreased cardiac output. This is the right answer. Okay. The third answer, decreased the preload due to massive fluid loss. That's wrong. That's the answer for a hypovolemic shock. Okay. Obstruction of pulmonary arterial blood flow causing right ventricular failure. That's the wrong answer because this is the answer for an obstructive shock. Okay. Peripheral vasodilation due to inflammatory mediator release, that's the answer for an anaphylactic shock. Okay, so I wish you got all this stuff. Okay, and thanks for watching and bye bye.